The topic of this video is drug therapy of glaucoma. In this video, we will cover what is glaucoma, the causes and the types of glaucoma and drug therapy of glaucoma. So what is glaucoma? Glaucoma is the result of damage to the optic nerve. As this nerve gradually deteriorates, blind spots develop in your visual field. This nerve damage is usually related to increased pressure in the eye. So increased intraocular pressure leads to glaucoma and damage to the optic nerve. How do you get glaucoma, or what are the causes of glaucoma? Elevated eye pressure or intraocular pressure is due to buildup of fluid, aqueous humor, that flows throughout the inside of your eye. The aqueous humor that is produced by the ciliary epithelium flows to the anterior chamber by passing between the lens and the iris. Then it flows through the pupil, leaves the anterior chamber by flowing through a tissue known as trabecular meshwork located at the angle between the cornea and the lens. Then it drains through the canal of sclem and regulates the intraocular pressure of the eye. There are two major types of glaucoma: angle closure glaucoma and open angle glaucoma. Angle closure glaucoma is also called closed angle glaucoma. It occurs when the iris bulges forward to narrow or block the drainage angle formed by the cornea and the iris. As a result, the fluid cannot circulate through the eye and the pressure increases. Some people have narrow drainage angles, putting them at increased risk of angle closure glaucoma. Angle closure glaucoma may occur suddenly, which is also known as acute angle closure glaucoma, or gradually, that is chronic angle closure glaucoma. Acute angle closure glaucoma is a medical emergency. Open angle glaucoma is the most common form of the disease. The drainage angle formed by the cornea and the iris remains open, but the trabecular meshwork is partially blocked. This causes pressure in the eye to gradually increase. This pressure damages the optic nerve. Next, drug therapy of glaucoma. So what are the drugs used in the treatment of glaucoma and the mechanisms responsible for lowering the intraocular pressure? The first group, cholinomimetic agents, which includes directly acting cholinomimetic agents and indirectly acting agents such as anticholinesterases. The directly acting cholinomimetics includes pilocarpine, and the indirectly acting cholinomimetic agents, which includes anticholinesterases, are physostigmine, ecothiopate. Cholinomimetic agents stimulate muscarinic receptors, particularly the M3 receptors that are present in the circular muscle of the iris, that is sphincter pupillae, and the ciliary muscle of the eye. The ciliary muscle contraction and constriction of the pupil pulls the iris, opening the trabecular meshwork, and facilitates the drainage of aqueous humor and reduces intraocular pressure. The next group is beta blockers. In the eye, beta receptors, largely beta 2 subtype, are present in the ciliary body epithelium and the blood vessels. Production of aqueous seems to be activated by a beta receptor mediated cyclic AMP protein kinase A pathway, and this results in the formation of aqueous humor. So beta blockade blunts adrenergic activation of this pathway by preventing catecholamine stimulation of the beta receptors. Also, it has been reported that beta blockers decrease ocular blood flow, which decreases the ultrafiltration responsible for aqueous production. The beta blockers include timolol, betaxolol, cartiolol, and levobunolol. The next group is alpha agonists, which can be non-selective and selective alpha agonists. The non-selective alpha agonists are epinephrine and dipivefrin, whereas the selective alpha 2 agonists are apraclonidine and brimonidine. Alpha agonists facilitate outflow of aqueous humor via the uveoscleral veins. They reduce the formation of aqueous humor by alpha 2 receptor agonist action present on the ciliary epithelium. The next group is carbonic anhydrase inhibitors, which includes acetazolamide, dorzolamide and brinzolamide. Carbonic anhydrase enzyme plays an important role in aqueous humor formation. Carbonic anhydrase inhibitors reduce the aqueous humor formation by decreasing the formation of bicarbonate ions in the ciliary epithelium. The next group is prostaglandins, which includes latanoprost and bimatoprost. They reduce the intraocular pressure by increasing uveoscleral outflow. The next group is hypertonic solutions, which includes mannitol, glycerol. They reduce the intraocular pressure by inducing intraocular dehydration by osmotic action. So now let's talk in details about anti-glaucoma drugs. The first group, that is cholinomimetic agents or miotic agents. The drugs are pilocarpine, physostigmine, ecothiophat, carbachol. They are used more commonly in closed-angle glaucoma than open-angle glaucoma. The drug of choice is pilocarpine in closed-angle glaucoma. The mechanism of action is increased trabecular outflow. The side effects are ciliary spasm or accommodation spasm, as the eye is focused or accommodated for near vision. There is induced myopia, retinal detachment and corneal edema. A specific adverse effect of topical anticholinergics is cataract in case of ecothiophat and physostigmine. Therefore, these drugs are contraindicated in phakic patients. Ecothiophat is known to cause iris cyst and nasolacrimal duct obstruction. The next group is sympathomimetic agents or alpha agonists, which can be non-selective and selective. The non-selective alpha agonists are epinephrine and dipivefrin. Dipivefrin is a prodrug of epinephrine. It has a better penetration through cornea, better ocular tolerance and a longer duration of action. The selective alpha-2 agonists, which includes apraclonidine and brimonidine, are potent ocular hypotensives which do not cross the blood-brain barrier and hence they have no systemic side effects like clonidine. The mechanisms for lowering the intraocular pressure are they decrease aqueous production and increase uveoscleral outflow. Adverse effect that is common to epinephrine and dipivefrin is ocular allergy. Specific side effect of epinephrine and dipivefrin is conjunctival pigmentation. The next group is beta blockers. Topical beta blockers can be classified as non-selective and selective. The non-selective beta blockers include timolol, which is most potent agent, and the other drugs are levobunolol, metipranolol, cartiolol. The selective topical beta blocker is bitoxolol. So it is the longest acting beta blocker. The mechanism of action is decrease aqueous production. It is used as a second line management in open angle glaucoma. The adverse effects. Topical beta blockers can cause systemic adverse effects. Therefore, topical beta blockers are contraindicated to be given with systemic beta blockers. Beta blockers can precipitate bronchoconstriction by blocking beta-2 mediated bronchodilation. Therefore, they are contraindicated in bronchial asthma and COPD, specifically the non-selective beta blockers. The next group is carbonic anhydrase inhibitors, which can be classified as systemic and topical. The systemic carbonic anhydrase inhibitor is acetazolamide. It is useful in acute congestive glaucoma. The route is oral or intravenous and the side effects are metabolic acidosis, hypokalemia, hyperammonemia and nephrolithiasis. The topical carbonic anhydrase inhibitors are brinzolamide, dorzolamide. They are used in open angle glaucoma. The side effects are transient myopia, periorbital dermatitis and corneal edema. The next group is prostaglandin analogues. The prostaglandin F2 alpha analogues are latanoprost, bimatoprost and travoprost. The mechanism of action is increased uveoscleral outflow. It is useful in the treatment of open angle glaucoma and normal tension glaucoma. The dose is topical single dose at night. The adverse effects are pigmentation of iris, eyebrow, periorbital skin by increasing the effect of tyrosinase in melanocytes. It can cause cystoid macular edema, therefore caution is necessary in diabetes mellitus. It can cause overgrowth of eyelash, that is trichomegaly. Therefore, bimatoprost has secondary use in hypotrichosis, example patients taking anti-cancer drug therapy. And lastly, they can also cause dry eyes. These drugs are contraindicated in uveitis and herpetic keratitis. The next group is hypertonic solutions, which includes mannitol and glycerol. They can be infused intravenously. Glycerol is given orally. This brings us to the end of the topic. These are my references. Thanks for watching. Please like, subscribe and share.